Bismillahirrahmanirrahim. Quote of the day. Life is like a garden, you reap what you sow. Today, the topic of my presentation is natural history of disease, ways of expressing prognosis, and I am presenting it under supervision of my professor, Dr. Saransan. Learning outlines, natural history of disease, case fatality, 5-year survival, observed survival, median survival time, relative survival, two approaches for calculating observed survival over time, that is live table approach and the Kaplan-Meier method, and recent updates and MCQs in the end. Learning outcomes. By the end of this presentation, participants would be able to compare 5 different ways of describing the natural history of disease, case fatality, 5-year survival, observed survival, median survival, and relative survival, to describe 2 approaches for calculating observed survival over time, that is live table approach and Kaplan-Meier method, to illustrate the use of live tables for examining changes in survival. Natural history of disease. It refers to the progression of a disease process in an individual over time in the absence of treatment. It usually consists of these 6 stages. That is, first there is biological onset of disease, then pathological evidence of disease if sought, then patient suffers from signs and symptoms of disease, then he go and seek medical care, and after that diagnosis and treatment, and after that the outcome may be cure, control, disability, or death. So it usually consists of 2 phases: preclinical phase, that is from biological onset to the appearance of signs and symptoms, and after that clinical phase starts. For example, untreated infection with HIV causes a spectrum of clinical problems beginning at the time of seroconversion, that is primary HIV, and terminating with AIDS and usually death. Now, 5 approaches to expressing prognosis. These are case fatality, 5-year survival, observed survival, median survival time, and relative survival. Case fatality. It is the first way to express prognosis. It is defined as the number of people who die of a disease divided by the number of people who have the disease. So it is the ratio of deaths to cases. It is ideally suited to diseases that are short-term, acute conditions. It represents virulence of an organism and killing power of a disease, and time interval is not specified. So this is the formula of case fatality, that is, in numerator we have total number of deaths due to a particular disease over total number of cases due to the same disease multiplied by 100. Then comes 5-year survival. The 5-year survival is the percentage of patients who are alive 5 years after treatment begins or 5 years after diagnosis. This term is frequently used in clinical medicine, particularly in evaluating treatments for cancer. Despite its widespread use, it should be pointed out that there is nothing magical about 5 years. Certainly, no significant biological change occurs abruptly at 5 years in the natural history of a disease that would justify its use as an endpoint. However, most deaths from cancer occur during this period after diagnosis, so 5-year survival has been used as an index of success in cancer treatment. Now, there are some problems with 5-year survival. First is that with the use of 5-year survival, it has become more prominent in recent years with the advent of screening programs. For example, this is a small hypothetical example. This timeline shows that a woman who had biological onset of breast cancer in 2000, because the disease was subclinical at that time, so she had no symptoms. However, in 2008, she felt some lump, for which she visited her physician, who made the diagnosis. The patient then underwent a mastectomy. In 2010, she died of metastatic cancer. As measured by 5-year survival, which is often used in oncology as a measure of whether therapy has been successful, this patient is not a success because she survived for only 2 years after diagnosis. But now imagine that if she lived in a community in which there was an aggressive breast cancer screening campaign, and as before, again biological onset of disease occurred in 2000, but in 2005 she was identified through screening as having a very small mass in her breast. She had surgery in 2005, And again, she died in 2010. Because she survived for 5 years after diagnosis and therapy, she would now be identified as a therapeutic success in terms of 5-year survival. However, this apparently longer survival is an artifact because death, it is occurring in 2000 as in previous example. But the patient's life was, patient life was not lengthened by early detection and therapy. However, the interval between her diagnosis and her death was increased through earlier diagnosis. There was no delay in time of death. The interval between the early diagnosis in 2005 made possible by screening and later usual time of diagnosis in 2008 is called a lead time. This is a lead time, that is the time gained due to the early diagnosis by screening to the time of usual diagnosis. This is called lead time. Lag time is the advantage gained by screening. It is a period between diagnosis by early detection and diagnosis by other means. The benefit of the program must be seen in terms of its outcome. So this is the lag time. Now, second is another problem with 5-year survival is that if we want to look at the survival experience of a group of patients who were diagnosed less than 5 years ago, we clearly cannot use this criterion because 5 years of observation are necessary in these patients to calculate 5-year survival. Therefore, if we want to assess a therapy that was introduced less than 5 years ago, 5-year survival is not an appropriate measure. Uses. 5-year survival rates can be used to compare the effectiveness of treatments. Use of 5-year survival statistics is more useful in aggressive diseases that have a shorter life expectancy following diagnosis, such as lung cancer, and less useful in cases with a long life expectancy, such as prostate cancer. Improvements in rates are sometimes attributed to improvements in diagnosis rather than to improvement in prognosis. To compare treatments independently from diagnostics, it may be better to consider survival from reaching a certain stage of the disease or its treatment. Now, third method is observed survival. Observed survival is an estimate of the probability of surviving all causes of death for a specified time interval calculated from the cohort of cancer cases. This is a rationale for life table. That is, a life table is another approach to use the actual observed survival over time. For this purpose, we use a life table. Let us examine the conceptual framework underlying the calculation of survival rates using a life table. And this example shows a hypothetical study of treatment results in patients who were treated from 2000 to 2004. And these are the number of patients treated in each year. And so the patients who were enrolled in 2000, they were followed for 5 years. And the patients who were enrolled later in the study, they were not followed for the 5 years. So this is the rearrangement of data showing survival tabulated by years since enrollment in treatment, and there is no loss to follow up. For example, in 2000, 84 patients were treated, out of which 44 were alive at the end of first year, 21 were alive at the end of second year, 13 at the end of third year, and so on. However, the patients who were enrolled or who were treated in 2001, they were 62, and we would have their data for 4 years, but not for the 5th year. And so on with the 2002, 3, and 4. Now, how is the life table used? Our first question is that what is the probability of surviving for 1 year after the beginning of treatment? So to answer this, we divide the total number of patients who were alive 1 year after the initiation of treatment, that is 197, over total number of patients who started the treatment, that is 375. So the probability of surviving the first year is 197 over 375, that is 0.525. Now, second question is, what is the probability that having survived the first year after beginning treatment, the patient will survive the second year? Now we can see here that the patients who were alive at the end of the second year, they were 71. And the patients who were enrolled in 2004, they were not studied or observed further. So we will subtract 43, this value 43 from 197. So as we have no further information because they were observed for only 1 year, so in the denominator we subtract the 43 patients from whom we have no data for the second year, and the probability of surviving the second year is 0.46. Another case is that given that a person has survived to the end of the second year, what is the probability that he or she will survive to the end of the third year? Again, we can see here that 36 survived the third year, although 71 have survived the second year. But we have no further information on survival for 16 of them because they were enrolled later in the study. So we would subtract 16 from 71 and calculate the probability of surviving the third year, like keeping 36 as numerator. That is the number of patients alive at the end of third year. And denominator is 71 minus 16 because these 16 studies were not observed further because they enrolled later in the study. Now, if a patient survives to the end of the third year, what is the probability that he or she will survive to the end of the fourth year? Again, we will see that these are the number of patients at the end of fourth year, that is 16 over 36 minus this 13 value, and 0.696 is the probability that the patient will survive at the end of fourth year. And likewise, probability of surviving to the end of fifth year, that is, this is the figure. These are the patients who were alive at the end of fifth year over 16 minus 6, that is 0.80. So these are the probabilities of survival for each year of the study. And here they are converted into percentages, that is 52% for first year, 46.1 for second year, and so on. Cumulative probabilities of surviving different lengths of time. So this is the probability of surviving for the first year. And if we want to calculate the probability of surviving for 2 years, we would calculate by multiplying P1 and P2, that is 24.2. And if we want to calculate the probability of 5 years, we would calculate all the probabilities of each year, and the cumulative probability we would get of the 5 years. Now calculating a life table. Let us now view the data from this example in the standard tabular form, in which they are usually presented for calculating a life table. In calculating it, persons from whom data are not available for the full period of follow-up, either because follow-up was not possible or because they were enrolled after the study was started, or for withdrawals or losses to follow-up. So these are the 4 columns. This is the picture of standard format of life table. Column number 1 shows the interval since beginning treatment. Second column shows the number of study subjects who were alive at the beginning of each interval. Column number 3, the number of study subjects who died during that interval. And column number 4, it indicates the number who withdrew during the interval, that is the number of study subjects who could not be followed for the full study period, either because they were lost to follow-up or because they were enrolled after the study had started. So this is how we calculate a life table, in which we have further 4 columns. Column number 5 shows that effective number exposed to risk of dying during interval. How we calculate that? We subtract half of the values given in column number 4 from the values given in column number 2. Then column number 6 is proportion who died during interval. These are the died during interval divided by this column number 5 values, and column number 7 indicates the proportion who did not die during interval. These are calculated by subtracting the values given in column number 6 from 1. And these are the cumulative proportion who survived from enrollment to the end of interval. These are the cumulative survival for each year. Now, the second method is the Kaplan-Meier method. It is also a survival analysis method that uses exact time when events occur. In this, predetermined intervals such as 1 month or 1 year are not used. On the other hand, the predetermined intervals were used in life table. So rather, we identify the exact point in time when each death occurs, so that each death terminates the previous interval and a new interval started. The number of persons who died at that point is used as a numerator, and the number who alive up to that point is used as a denominator after any withdrawal that occurred before the point are subtracted. So this is an example of small hypothetical study in which 6 patients were enrolled, and out of these 4 were died and 2 were lost to follow-up. So deaths occurred at 4, 10, 14, and 24 months after enrollment to the study. And this is the calculating survival using the this Kaplan-Meier method. Again, these are the 6 columns. Column number 1 shows the time for each death from the time of enrollment. Column number 2 shows the number of patients who were alive and followed at the time of that death. Like there were 6 who were alive at each time, like at 4 months. And then the number who died at each time, it was 1, and proportion who died at that time is 1/6, that is 0.167, and proportion who survived at that time is 1 minus 0.167, that is 0.83, and cumulative proportion who survived to that time, that is cumulative survival, is 0.83. And this is the calculation for other 3 patients. Now the cumulative probability at each point is 83, 62, 42, and 0. And we can see that the data plotted it in a stepwise fashion rather than in a smooth slope, because after the drop in survival resulting from each death, survival then remains unchanged until the next death occurs. Application of Kaplan-Meier method. When information on the exact time of death is available, this method clearly makes fullest use of this information because the data are used to define the intervals. Although the method is well suited to studies with small number of patients, today computer programs are readily available that make this method applicable to large data sets as well. Many of the studies in the published literature now report data on survival using this method. So these are the assumptions made in using Kaplan-Meier method, that is censored individuals, that is those who have not experienced the event or who are withdrawn or lost to follow-up, they are usually no longer enrolled. And cohorts should have similarly group entering at different times should be similar, and occurrence of event are done at specified time. So these are the assumptions while using this method. Now, comparison of Kaplan-Meier curve vs actual tables. Actual life tables, it allows for censored data and cumulative probability calculations. And Kaplan-Meier survival, it also allows for censored data and cumulative probability calculations. Life tables are time dependent. However, this Kaplan-Meier is event dependent. Life table is unreliable in small data sets. Kaplan-Meier is reliable in small data sets, and the uniformity assumption in a life table is that uniform timing of censoring assumed. However, there is no assumption is made about the timing of censoring in Kaplan-Meier curve. Then comes median survival time. It is defined as the length of time from either the date of diagnosis or the start of treatment for a disease such as cancer, that half of the patients in the group of patients diagnosed with the disease are still alive. So median survival offers 2 advantages over mean survival. That is, it is less affected by extremes or outliers where the mean is significantly affected by even a single outlier. Second is that we use mean survival. If we use mean survival, we would have to observe all of the deaths in a study population before the mean could be calculated. However, to calculate the median survival, we would only have to observe the deaths of half of the group. So this is the graphical representation of median survival, that at 50% survival, for example, in this, there is 111 days. This is the median survival. Mean survival is the time that is estimated as the area under the survival curve in the interval T0 to T max. However, median survival is the length of time that 50% of the study population survives. Then comes relative survival. It is a way of comparing the survival of people who have a specific disease with those who don't over a certain period of time. It is thus defined as the ratio of the observed survival to the expected survival. So this is the formula for calculation of relative survival, that is observed survival in people with the disease over expected survival if disease were absent. So this is the table showing 5-year observed and relative survival by age. We can see that there is very little difference in younger age groups. However, there is greater difference between observed and relative survival in older age groups. Because in older age groups, we have high rates of mortality from other causes. So there is a large difference between the observed and relative. And in young persons who generally do not die of other causes, observed and relative survival for cancer of the colon and rectum do not differ significantly. This is the graph. In picture A, we can see that this is a perfect survival curve of 100% over 10 years of study period. And this big graph shows that this is an actual survival observed in group of patients with disease over 10 years. And this expected survival for group of 80-year-old man, which is clearly less than 100%, because deaths from other causes are significant in this age group, because these are the graphs of people of age 80 years. And this is the relative survival, which is observed survival over expected survival. Now, recent updates. This is an article titled Mean Survival or a Median Survival, which measure is most appropriate for patient, physicians, and policymakers. According to it, median survival is the most common measure used in the outcome reporting of oncology clinical trials and easy to understand. However, it describes only a single time point. So the interpretation of hazard ratios difficult and its underlying statistical assumptions are not always met. So the objective of this study was to relate alternative measures based on the mean benefit of novel oncology treatments. It concludes that the mean survival may supply valuable information for different stakeholders, so its inclusion should be considered in reporting of prospective clinical trials. Another study the effect of exclusive breastfeeding on child survival using modified Kaplan-Meier model. In this survival analysis, this estimator serves as a tool for measuring the frequency or the number of patients surviving medical treatment. Kaplan-Meier estimates of survival data have become a better way of analyzing data in cohort study, and it is a non-parametric estimate of survival function that is commonly used to describe survivorship of a study population and to compare two study populations. And this model has been verified, and the findings agree that the life expectation will be improved by 99% of children are fed exclusively breast milk, while the lifespans being reduced that can lead to death by 30% if the children have a mixed feeding, which agrees with why exclusive should be done. Now, moving on to MCQs. MCQ number 1, in an epidemic of hepatitis A traced to green onions from a restaurant, 555 cases were identified. 3 of the case patients died as a result of the infections. Calculate the case fatality rate. 3, 1.5, 0.5, 1, 3.5. It needs a little calculation. Any guess? Okay, so here the deaths due to the case is the number of deaths are 3 and the number of cases are 555. So 3 over 55 is 0.5%. So C is the right option. MCQ number 2. In survival analysis, we use information on event status and follow-up time to estimate a survival function. Consider 20-year prospective study of patient survival following a myocardial infarction. In this study, the outcome is all-cause mortality and the survival curve might be as depicted in the figure below. Which of the following is not true regarding this graph? At time 0, the survival probability is 1. At 5 years, the probability of survival is 83% or 0.83. At 10 years, the probability of survival is approximately 55% of 0.55. The median survival is approximately 11 years.
B.
Yes, B is the right option because we can see that 83 or 0.83 survival is at 2 years, not at 5 years. Based on the below given Kaplan-Meier curve, what can we understand about the median survival time of group 1 versus group 2 during the study? Group 1 has median survival score half of the patient treated in group 2. The median survival time of group 1 is approximately 15 years. Group 1 has overall reduced survival time compared to group 2, and median survival time for group 2 is 8 years. The median survival time for group 2 is half of that of group 1. This line might help you. This line might help you that at 50% survival probability, it is usually at 22 years for group 1 and 8 for group 2. So group 1 has more survival than group 2. So A and C are the wrong option. Again, median survival of group 1 is approximately 15 years. This is also wrong because it is 22 years. The median survival for group 2 is 8 years. This is the right option. So D is the right option. Based on the below Kaplan-Meier curve, which group had a better 10-year survival prognosis? Group 1, which has a 10-year survival prognosis of 40%, Group 2, which has a 10-year survival prognosis of 16 years, Group 1, which has a 10-year survival prognosis of 80%, or Group 2 is has less survival than Group 1. Any idea? We can see that at 10-year survival, prognosis is 80% for group 1. So C is the right option. MCQ number 5, which of the following is a good index of the severity of short-term acute disease? Specific death rate, 5-year survival, case fatality, standardized mortality ratio.
C, case fatality.
C is the right option. MCQ number 6, a diagnostic test has been introduced that will detect a certain disease 1 year earlier than it is usually detected. Which of the following is most likely to happen to the disease within the 10 years after the test is introduced? Assuming that early detection has no effect on the natural history of disease and no change in death certification process occurs during the 10 years. So option A is period prevalence rate will decrease, apparent 5-year survival will increase, the age-adjusted mortality will decrease, the age-adjusted mortality will increase, the incidence rate will decrease. This might help you. Yes, B is the right option.
B is the right answer.
MCQ number 7. The Kaplan-Meier survival curve is defined as the probability of surviving in a given length of time. Which of the following is not true about it? It uses the exact time when events occur. It uses the predetermined intervals of events. It is useful for small sample size studies. The plot may display prognosis over time. B is the right option because lab table uses the predetermined. Yes, B is the right option. MCQ number 8. A total of 180 patients were treated for disease X from 2014 to 15 and their progress was followed to 2016. The treatment results are given in the table. No patients were lost to follow-up. What is the probability of surviving for the first year after the beginning of treatment? 84%, 75, 60, 55, 50. It needs
60.
No, it needs a little calculation. A is the right option. That is probability of surviving the first year is, we can see that here we will keep 152 as numerator over 180. So 84 will be the right option. Keeping in view the same table and probability of surviving for first year, how would you calculate the probability of surviving for 3 years? So here the right option again is
55.
No, it is 84. We will calculate probabilities for each year, that is for 3 years, one by one. And after that, we will multiply all the probabilities and the result we would get is 84%. MCQ number 10. Median survival time is defined as length of time that half of the population survive. Which of the following is not true regarding median survival? Median survival is preferable over mean survival time. It is affected by extremes or outliers. It needs whole of the population to be studied for event of interest. It captures the long-term survival profile well. Which of the following is not true? C is the right option because mean survival time needs whole of the population to be studied. However, for median survival time, we usually study 50% of the people enrolled. This is the key of MCQs, and thank you.